So, as COVID-19 continues, so does the rest of general internal medicine, and so do our educational missions. And I think we have just been so lucky to have, I'm going to call you the fabulous five. So Jared, Jonathan, Audrey, Katie, and Chris, to really kind of lead us through not just the whole year, but especially this time during COVID-19, where I think medicine has taken the lead on many of the different initiatives, and primarily patient care as well as education. So I just want to say a couple of words about each of you as we get ready for this update on medical innovations. So Jared is our conference chief, as you know, and has created an app. And let me tell you that the entire medical center is desperate to see this app. So we're looking forward to that being launched. I know you didn't design it initially for COVID, but it's going to be very helpful for those folks who are not quite as familiar with the medicine side of life. Of course, you're going to be a prominent critical fellow here at VCU, so I'm looking forward to working with you on the floors and the ICUs. Jonathan is our quality improvement and patient safety chief, and he is going to be going off to do cardiology up in Roanoke. So we definitely wish you the best, and I'm sure your quality improvement and patient safety spin on life will be very useful in that role. Audrey, our ambulatory chief and our Twitter chief. You are going to be going off to be a hospitalist at Emory. We will miss you, and of course, you're going to do a great job up there. Katie, thank you for all you're doing as the teaching chief and the virtual learning chief now that we've had to go online with much of the clerkship. And you're going to also join Prominent Critical Care up in Tufts. So we're looking forward to hearing of your progress, and I look forward to seeing you at the ATS meetings when we get back to doing this in person. And Chris Young, who is our intern chief, but also I'd say our chief morale officer. Who else could get me to dress up as a unicorn? And who else could manage to hold a cornhole tournament and an I Am Idol when we're all busy with COVID? So great that you're able to do all these things, as well as all of the important work that you've done with the interns. So know how much your work is appreciated, not just by me, but by the entire medical center. This is a moment where I think you've all shone, and of course it was no surprise to any of us. And special thanks to Stephanie for helping to set this up, and for Dr. Miller as well. Great leaders, and we're looking forward to today's presentation. Thank you.
All right. Thank you, Dr. San. I'm going to go ahead and get started. Again, my name is Chris Young. I've had the privilege of serving as the intern chief this year. I think I speak for everyone who's going to be standing up here today when I say just how honored and how thrilled we are to be able to get up here and talk about a topic that is really near and dear to us, and really near and dear to the Department of Medicine. And as you can see, we're going to be talking about innovation and educational innovation in the medical world. So I'm going to go ahead and get started. So first of all, we have no disclosures. The learning objectives for this talk. So at the conclusion of grand rounds, our plan is to familiarize you as the audience with educational innovations throughout the Department of Medicine. We are thrilled to participate and be a part of a department that is really innovative, and we are going to choose to focus and highlight 4 of those innovations that we've been able to be a part of this year. So first is going to be MS4 near peer teaching, so at the undergraduate med ed level. Second is going to be emergency response training. It is going to be our updates to our core conference series this year. And fourth will be medical Twitter, and in particular as it pertains to expanded learning networks. We are super excited to be able to do this and to have played these roles within a department that really does focus on innovation and puts a real focus on education. And it's our mission to really push that during this talk. And as you can see, one of our core values in the residency program, this residency program in which we're all trained, is to contribute to the science and art of medical education through innovation in training methods. We are really proud of the fact that all 4 of these innovations that we're going to tell you about contribute really across the continuum of medical education. And that starts at the undergraduate med ed level. You can see some intrepid 4th year med students right there. moving forward into the learner manager phase. And we'll talk about the emergency response training at the VA that is really built on that curriculum. The teacher leader phase and the goal to graduate competent internists of the future. And then moving on with the attending level, continued skill building in knowledge acquisition and moving forward on how medical Twitter can contribute to that. So I am going to hand things over now to Katie Waybill, who is going to tell you about near-peer teaching.
Thank you, Chris. My name is Katie Waybill. I am the resident chief this year, and I have the opportunity to talk about the first place that the Department of Medicine has the opportunity to work with learners, and that is with medical students. So whether this is with first and second year medical students who are doing their IM interest group, third year students in the clerkship, or our acting interns, we have the opportunity to really reach these learners at an early phase in their training. And one of the projects that we have done is using near-peer teaching as a way to train our next generation of teachers. So near-peer teaching is teaching that occurs between a student and a teacher who are at similar levels on the medical education spectrum. This can be between a senior resident and an intern and an M4 student, or even between two medical students, one of whom is a senior student and one of whom is a junior student. It's been used in a variety of settings, including here in our School of Medicine in the anatomy lab, but not commonly in internal medicine. And a few years ago, our acting interns transitioned from being on our house staff services to more primarily on our hospital medicine services. And so they lost the opportunity to teach their near peers, which is how this project was born. A little bit of background is that 78% of internal medicine program directors believe that the ability to teach medical students is an important factor in assessing resident success. Unfortunately, many medical students are not taught formal teaching concepts during medical school and have limited opportunities to develop skills prior to the start of residency. So one of those important things that they're being evaluated on, they've really had no experience with before entering internship. We implemented a near-peer curriculum in the internal medicine acting internship starting in 2018. This was spearheaded by Dr. Adam Garber, who ran orientation by teaching key steps in facilitating an effective teaching session, and then gave the students a teaching topic from a list of predetermined cases. As you can see here, these are very common things that we encounter in internal medicine, and so these were opportunities for our students to work with topics with which they were familiar and to teach them to their peers. 49 students then went through the acting internship and presented case-based teaching sessions to the IM clerkship students, while an attending observer provided formative feedback on their teaching sessions. Each of these teaching sessions looked fairly similar. On Friday afternoons, two acting interns would give a 30-minute teaching session that could be presented really however they wanted. It could be them presenting the case up front and asking the students to form a differential. It could be them prompting the M3 students to ask for more probing history questions or physical exam findings. And the students were really encouraged to set forth learning objectives for the session and to build their case format into really meeting these learning objectives. They could use a variety of teaching techniques such as advanced organizers, mnemonics, and other things in order to promote understanding and retention of the data they were teaching. And then after the session, they were provided with formalized feedback from a faculty observer, and they provided feedback to their partner. I would be remiss if I did not say thank you to the teaching chiefs who preceded me. These are the 6 folks who really were the core at giving the feedback to our acting interns as they were teachers. So starting with Michael Leroux and then going through Ariella Crones, Danny Johnson, Zach Benson, Jared Dyer, and Chris Young. These people were really crucial in making sure that our acting interns were able to continue to grow as teachers. After the acting internship was over, 34 students completed a pre-post survey about their experience with the near-peer teaching project. And some of the testimonials that came out of this survey said that the students had been using their skills from near-peer to help them prepare for morning report sessions. They found it as a way to effectively teach subjects and engage with their audience. And one of our current interns actually said that he enjoyed this opportunity and wished he could do more kinds of things like this with his medical students. When we looked at some of the objective data, we assessed how well we succeeded in increasing confidence with the learning objectives. And you can see here that the pre-columns in gray and the post-columns in yellow really show an improvement in the confidence of our learners in preparing a learning session, leading a teaching session, presenting in front of students, answering questions about their topic, and on giving feedback. When we asked the students about some perceived benefits of the near-peer experience, for many of the benefits, over 90% of students were in agreement that near-peer was helpful and an effective way to gain teaching experience, feel better prepared for the teaching requirements of residency, and to prepare them for teaching sessions and using them as a new way to expand their learning. Overall, we think that near-peer teaching is an effective method to provide teaching experience not otherwise available to medical students. It improves confidence with teaching prior to starting residency, and it was generally positively reviewed by our M4 students. Looking forward, we are hoping to create a teaching elective within the School of Medicine that's accessible to all M4 students and available across a variety of specialties. And during this elective, the students would have the opportunity to focus on education and teaching outside of the clinical demands of the acting internship. At this point, I would like for Jonathan to come up to talk to us about emergency response training.
Thanks, Katie. So I'm Jonathan Hilliard, and I have the privilege of talking to you all about our emergency response training curriculum. So for those of you that don't know, I'm the Chief Resident in Quality and Patient Safety, and most of my home base this year has been at our VA hospital, but the beauty of this position is you really get to work with a lot of the leaders across both of our hospital systems, both at the VA as well as here at VCU. So I'd like to propose a question to the group. So what does it mean to be a well-rounded internist? So I think back on our training, myself and my co-chiefs, we finished training less than a year ago. The curriculum that we're using now in our program is already different than what we received. And thinking about 30 years ago, the curriculum has continued to evolve. So it's really making us well-rounded. And the beauty of this is we can adjust a curriculum to evolve with our training. We also have this wonderful thing we call ACGME milestones, which basically are competencies for us to follow so that we know we're training well-rounded internists. So I'd like to take a step back and look at the wonderful things that our hospital system's doing, both at VCU as well as the VA. But at VCU, we have this wonderful code training that takes place. We have a great simulation center in the medical school. And that training is actually something that myself as well as my co-chiefs went through during our PGY2 summer series. We were trained to participate in mega codes, participate with looking at multiple patient scenarios. But this year we took a step back and we said, where is our curriculum going? Where has it been evolving to? And that brought up our next question of, again, what makes a well-rounded internist? And back to our initial question of, what are our ACGM milestones supporting? So if we look at a few of these milestones, we see that we want internists to gather and synthesize essential and accurate information based off different patient clinical scenarios. We want them to develop and achieve comprehensive management plans. And importantly, we want them to have progressive responsibility and independence as they're growing. So we go back to this initial question of what makes a well-rounded internist. Well, if we need some curriculum restructure to really support that, we might have to go back to the start and say, what do our interns and what do our residents actually need? So putting on my QI mind here for a second, for any of those who are involved in quality improvement projects, the first thing that we do is we think about identifying a need for change. And there is a lot of different components when we think about this, but some here, you talk to program leaders, you talk to house staff, you talk to safety committees, we look at patient safety reporting systems, and those will help us identify things that we might need to change. So then as a department, we want to look at things and say, if we think we might need a curriculum restructure, how can we assess a need? So what we did is looking at patient safety reporting systems, talking to hospital and program leadership, looking at house staff concerns, and you look for themes. It was really interesting. We found a theme that centered around concerns about patient emergencies, and that theme was actually central to our VA hospital. So we dove in a little bit more and we said, okay, there's this theme that's proposed. Well, let's think about who's involved. Let's think about the current system. How are our house staff involved? And is the current system actually being followed? And back to our other training that we had as second-year residents, we want to evolve this curriculum to really support the growth of our program and what it truly means to be a well-rounded internist. So we dove into the system a little bit. And we looked at the VA, and I have to acknowledge the wonderful leaders at our VA hospital who've done an amazing job restructuring this algorithm. So looking at our rapid response algorithm, this is a fairly complex system. It all starts with a clinically decompensating patient. But how are house staff involved? That's the really important thing. We want to make sure our curriculum is falling in line with where we want them to go. The other thing I'll move towards is it was interesting. We found this thing when a rapid response team arrives, there's this thing called an eye crash method. And we said, well, what is that? Well, this was actually really interesting. Dr. Angela Love, one of our pulmonary critical care providers, had been doing ongoing training with our hospitalists at the VA. And so we wanted to work in parallel with them and say, well, if the house staff aren't actually involved in this, let's figure out how we can work together. This was actually a standardized algorithm that was developed so that every single rapid response sort of ends up being the same. There's nothing that's missed. It was a wonderful standardized algorithm for them to follow. So then we flip over and look at our Code Blue algorithm. Again, commenting on the fact that this is an incredibly complex system, always starting with a decompensating patient. And you can see our members in blue here, which is all the members of our Code Blue team. Our complete algorithm is even more confusing. And the whole purpose of showing this is we're seeing that our system is complicated. It was very well thought out, and a lot of work had been going into this. I certainly cannot take any credit for this. But the complex system that was there was really, truly interesting. But our question goes back is, where are house staff involved? So when we're looking about any curricular change and we're moving things forward, the question we always want to ask is, where are areas for possible intervention? And what we looked at is saying, well, perhaps throughout this complex algorithm, maybe we might be missing something to make that well-rounded internist and fix that gap in that theme we found centered around patient emergencies. So we went to the residents and we asked them why. What do you guys think? And what we did is we looked at a self-assessed preparedness. And we said, how prepared do you all feel in different scenarios? Rapid response, Code Blues, and I'll draw your attention all the way to the right, applying the rapid response framework that our hospitalists were being trained in. And they didn't know. So we found that may be a need. So we looked at their attitude, and the attitudinal assessment of our residents actually was fairly strong. They knew that they wanted to respond to rapid response. They knew they wanted to respond to Code Blues, but really importantly, as 100% of them said, I play an important role, which is outstanding. So we look at the literature. So we've identified this theme. We know there's a concern for patient emergencies, but what has been done before? There's a lot of studies supporting emergent care, but one in particular is a provider, Diane Wayne. She was from Northwestern University, and she basically took two groups of residents. She took third-year residents and first-year residents. Her third-year residents were traditionally trained, no simulation, standard care prior to this implementation of simulation. And then she looked at simulated-based training, and she said, I have a bedside clinical assessment performance scale. And she found that it went from 80.9% to 91.3% from traditionally trained to simulation-based trained. So clearly, some positive effect of our simulation-based training. So then we think about, well, how can we change things? How can we make that well-rounded internist by supporting our curricular evolution? And back to our well-rounded internist, we want it to support our ACGME milestones. We want our clinical competencies to be achieved, but we really want to make sure that we're centralizing it to a patient emergency, a broad term. Can we assess clinically decompensating patients? Did you all remember that algorithm started out with a clinically decompensating patient? So our first cycle of intervening on this was, we want to align with our current training that was being done at VCU. It's a wonderful, wonderful program, but our restructure was, maybe we could perhaps tweak things a little bit. So we have a rapid response in Code Blue event that has to be involved. We have our second year internal medicine residents. We want it to be simulation centered. We want to have some type of didactic component. But our change was we want it to align well with our ACGME milestones. We really want to support that well-rounded internist. And because we found this need at the VA hospital, we decided, let's use our VA. Let's work in parallel with what we have at VCU. Let's figure out how we can develop an emergency response training. That's what we did. We have our emergency response training curriculum, which has a little bit of a unique flavor to it in that we really want as well-rounded internists to support initiating management of a rapid response. We want to teach them the iCrash method in parallel with what was going on at the VA. Code Blue events, we want residents to know how to initiate Code Blue management. We want them to know the indications for ACLS. So this training has been amazing. This is a picture of 3 different pictures of our training with some of our second-year residents. We started out this section or the training with about a 10-15 minute didactic session where we really taught the principles of initiating emergent care. We reviewed ACLS, we reviewed dosing of drugs, but we really taught them about their responsibility. And then we did simulation, and it was so much fun. With these pictures, we have one of our associate program directors, Derek Weiner, helping facilitate a discussion and helping support Maha, our resident here, lead this event. All the way over to the right, we have one of our pulmonary critical care fellows, Michael LaRue, who's actually debriefing with our residents. And we spend a lot of time thinking, how could we make it better? And what things did you do well with initiating this management? So we went back to our data and we said, how did things change? Now, acknowledging that this is immediately after the training, but we looked and said, how prepared do you all feel after performing this training? And it was amazing. All the numbers went drastically up and residents felt comfortable. They felt confident. We looked at the attitudinal assessment, and I think it's really important to note here that the numbers didn't change too much. I think this is fascinating, but really showing that our residents care about patients. They want to respond to rapid responses. They want to respond to codes, and they feel that they have an important role when doing so. We also did a knowledge assessment. We took about a 6-question quiz that had standard questions for dosing of drugs or what different things of our iCrash framework at the VA stood for, and we showed immediate knowledge retention from 62 to 92%. So none of this would be possible without the wonderful leaders we have across the Department of Medicine. I've gotten a lot of support, and it's been amazing to watch this program grow. This is not an exhaustive list. This is just a few of the providers that have helped us through, but it's pretty amazing when you have so many stakeholders that help support you. So where are we going with our future? And as we're talking about this evolving curriculum, so my goal is to have a 6-month knowledge reassessment for knowledge retention. So for those second-year students who are currently listening, yes, you all will get another survey, but our hope is to grow this in alignment with what we're doing at VCU, grow this in alignment with what we're doing at the VA to really adapt to that curricular change that we're seeing over the time course as we move forward. I'd love to add more additional patient scenarios, support all those ongoing curricular changes, and more importantly, collaborate with all the subspecialties. The growth of this is going to be amazing. I'm really excited to be telling you all about this. So I'd like to now turn it over to Dr. Jared Dyer.
All right, thanks, Jonathan. So I'm Jared Dyer. I'm the conference chief this year. And so I'd like to walk you through some of the changes that we've made over the past year with regards to core conference. Now, with that being said, VCU Internal Medicine has been at the forefront of innovation with regards to conference and conference structures dating back to 2005, when they made the change from the daily noon conference to the academic half day. This was done, in effect, to increase core conference attendance. And what they saw is even after one PDSA cycle, there was a dramatic increase in core conference structure and continued this. However, one of the most common questions that we get from our residents, as well as from our internal medicine residency candidates, is why the academic half day? And so I'm just going to walk you very quickly through a study from 2014 from the Cleveland Clinic to even confirm why we're continuing to do this. So in 2014, the Cleveland Clinic took some of their residents, continued them in their academic half day, and then continued the other half in the noon conference. And then they looked at their internal medicine in training exam, as well as looked at a resident survey. Now, I do want to bring to your attention that there was a discordant amount of people in the noon conference compared to the academic half day. So what was intriguing was the main findings. The academic half day showed to have increased attendance, better arrival time to conference, a reduction in conference disturbances and having to leave, increased satisfaction, and importantly, increased ITE scores by 4.8%, which we know has a direct correlation with board pass rates. So to put this all in context for you, we want to improve ITE scores, we had better conference attendance, we had less disruptions with core conference, and we had increased satisfaction with teaching format when we use the academic half day, which is why we continue to use it today. Now, how are we doing? I always looked at things as big chunks. And so when we looked at our core conference satisfaction rates, we saw that there was a negativity factor of around 16.8% from our annual program survey from 2017 to 2018. We go the next year, and that has come down to 12.1%. All right, so we're making improvements. But the question is why? Why has not we come down in that value? And so one of the things that we looked at with our educational steering committee is how do we improve that? How do we take our residents and increase them to the adult learner where they have all the skills to continue their education once they're out in the workforce? And so we decided to institute some core conference changes. And we looked at the resident comments. They said, I'd like to see more guidelines in our talks. And we'd like to see more evidence-based medicine, as well as to prepare us for boards. And they also said they wanted to be interactive and really focus on diagnosis and management because they really want to apply it to their real-world scenarios. So we have completely restructured our resident physician core conference this year with a focus on elevating that adult learner, allowing them to get real-world application through guidelines, as well as providing them with evidence-based medicine. So we have formed a 3-hour curriculum that has focused on clinical guidelines for the first hour, followed by clinical updates, and then a rotating curriculum. So we're just gonna break these down individually. So with our clinical guideline hour, the residents are reviewing the guideline that is sent out by a faculty facilitator the week before. They review 1 to 2 current guidelines, and then the facilitator talks about the highlights of the guideline, how the guideline was developed, and most importantly, the clinical application. How can they apply that to their everyday practice? In the second hour, we have clinical updates, where the faculty members are providing the identification of 3 to 5 clinically significant articles that have been published in the last 12 to 15 months. They assess the strength and the scope of the evidence that is found in that literature. And then most importantly, how do the residents apply that to their everyday practice? So here's an example from this year with our clinical guidelines. This was an example from Dr. Danielides with the Division of Rheumatology, where she's discussing using DMARDs for rheumatoid arthritis. You can see she's clearly using an algorithm to help residents understand when to use methotrexate. And then she also provides the evidence behind the guideline. Why are we using these different treatment modalities? But again, most importantly, is the application. So I'd like to highlight Dr. Call, who did a guideline talk just a few weeks ago on C. diff. She had the residents read the guidelines and then asked them to apply it to real world scenarios. So they're getting that application on to help them promote education throughout their training. For our clinical update example, Dr. Scott Matherly, through the Division of Hepatology, talked about corticosteroids in alcoholic hepatitis versus pentoxifylline. And what he showed is he gave his own conclusions from the articles and then gave the residents the opportunity how to apply this to their real world practice. And so the residents were able to take something away and apply it to their daily practice, which is the most important part of core conference. So how are we doing? So we look at over the last few years, we've actually made a dramatic reduction in that negativity factor. We've reduced the negativity level by 7.1%, but we still have room to grow, all right? So what are the residents saying from our annual program survey? They love it. They said the conferences are more intellectual and they provide insight into subspecialty care. They think that it's more engaging and provides them with current evidence. And then most importantly, I found this one to be, this really stood out to me in the fact that they said they are leaving each session with important points to help them guide their practice. So we've also made changes to our rotating curriculum. The rotating third hour has had the components for the last several years. Those are Balance, which is a small group session that is focused on the patient-physician relationship. There's also Pathways that allowed residents to focus on hospital medicine or global health or even subspecialty care. There's Business and Medicine, where they kind of learn the nitty-gritty of how to bill and kind of the things that go behind the scenes of being a physician in the community. And there's also House Staff Meeting. But we've made changes here. We've completely revamped Pathways with the help of Dr. Mandy George into a curriculum called Careers in Practice. Again, taking the resident, allowing them to be adult educators as well as adult learners, and to be able to choose what they want to do to help guide their future careers, right? Now, this was all done at the help of our Educational Steer Committee, where we talked about different polarity models. We also discussed it with the residents in our annual program survey. And we've also made some changes in Business and Medicine and added on a portion to that called Quality, Safety, and Advocacy, which I will talk about in just a few minutes. So, but going back to Careers in Practice, we had to make some changes. The residents thought that they needed some help building a strong CV so they can get a fellowship. They wanted to be able to, how to write a paper, what is the difference between academic medicine versus private practice, how to negotiate contracts. And so with our Educational Steering Committee, we were able to make that change. So what is Careers in Practice? So it focuses on career preparation, where they learn how to write a strong CV, how to negotiate contracts, and we have private practice members of the community come and speak to our residents to provide them with that information. We also get practice skills. So here's a picture of Dr. David Jesse showing residents how to use a Zoll appropriately. We also have Dr. Melissa Gillen come in to provide how to do joint exams. We also have our residents preparing for research. The residents are able to give their scholarship talks to various research faculty throughout the institution. Dr. Sterling's been heavily involved, as well as Dr. Call. And these residents are able to provide their talks that they're giving at the local, state, national, and even international level with the help of some of our outstanding faculty here at VCU. They're also being prepared for fellowship. They're getting that CV talk again. They're how to do a fellowship interview appropriately and having program fellowship directors help guide them through that. We also have included healthcare disparities, and Dr. Sarika Modi has done an amazing job of incorporating this into this conference series. She's talking about homeless populations, she's talking about LGBTQ, as well as other social determinants of health, and really exposing the residents to a wide array of the patients that we see on a daily basis. So how are we doing here? It seems to be overall very well perceived, and we're going to continue this and even improve upon it. Now, quality, safety, and advocacy, and the question is, why did we add this? Well, it's actually an ACGME requirement for our residents to be able to systematically analyze their practice and how to improve their practice. And they also should be aware of the responsiveness to the large context of a healthcare system, as well as social determinants of health. So what does this look like? So the quality, safety, and advocacy is a rotating curriculum that includes epidemiology, healthcare disparities, and patient safety. Now, there are a ton of thought leaders that are going into this curriculum, and I'd like to highlight some of them. Dr. Cheryl Garland, who has been an amazing, amazing contributor to this curriculum. She has come and spoke to our residents about social determinants of health, not only from a national standpoint, but even at the local level. She's also come in and talked about programs that our residents can get involved in to really help their patients that they're taking care of on a daily basis. We also have some of our patient safety thought leaders that include Dr. Georgia McIntosh, Sarah Hartigan, Dr. Derek Leiner, Evan Metters, and Dr. Monica Hazelrig at the VA. They're all coming in and providing real-time data to our residents about various safety events that are going on at our hospitals and how they can improve their practice from that. I'd also be remiss if I didn't bring Dr. Michelle Dahl into focus. She has come to our and spoken to our residents multiple times about real-time data regarding epidemiology, providing them data on hand washing, about central line associated bloodstream infections, and really helping the residents change their practice. So how are we doing here? Again, we're doing fairly well, but we still have room to grow, right? So what does the future look like for our core conference series? Well, I think we have some areas to grow, including helping our faculty make these sessions more interactive. That has become a more consistent theme in our annual program survey, and we will work to make that happen. We also work with our faculty to pare down some of the content that they're providing our residents to help them focus on what a general internist needs. So regardless if you're going into subspecialty practice versus if you're a generalist, you're gonna have the information you need to change your practice. We're also gonna use the in-training exam data to better direct conference topics. Where we are struggling, we can really help our learners even step it up another level. Okay. And with that, I will turn it over to Dr. Jernigan.
Hi, I'm Audrey Jernigan. I'm the ambulatory chief this year, and I get to talk about Twitter and expanded learning networks. So let's start with how we got here. Before any of us were even interned here, the 5 of us, there was an assessment done of our residents, and it looked at what their learning networks look like in general. And they found they were relatively limited. A lot of people were not using a lot of resources outside of VCU. And this is kind of what leads us to Twitter. Twitter is a social media platform, but it was quickly discovered by people in medicine and doctors that it is a wonderful education tool. It allows us to share resources, including papers and images, videos, audio clips across the world almost instantaneously. And this led to Stephen Bishop realizing that this is an excellent way that we could expand our residents' learning networks by using Twitter. And he started the project with that goal in mind. Soon afterwards, Nate Warner started our VCU internal medicine Twitter account that you will see lots of today. And over the next couple of years, Twitter kind of organically grew in our department. A lot of people started to tweet individually and started to expand their own learning networks. And that's the wonderful, rich Twitter environment the 5 of us got to walk into and take over this project just where it left off. We had the exact same goals as when Dr. Bishop started this. We wanted to expand resident learning networks and to promote self-directed learning. And we do this through our VCU internal medicine residency account, which through a process called retweeting, we are able to use a central location for people to share all of the different conversations that are going on at VCU that we feel our residents can learn from, and those that are going on outside of VCU, and a great starting point for our residents to come and start expanding their network using ours. So instead of trying to explain what tweeting and retweeting and hashtagging and tagging and all of that actually is, I'm going to try to take you through a day of what it looks like on our Twitter page and see if I can show you exactly how powerful this teaching tool is. The day you're going to see is just the day I started working on this, sometime back in February. But I feel confident you can look at it any day and it's going to look like this. And I hope you do look at it. I think today should look like this, yesterday should, and the day before that. So the first tweet I'm going to share is one by one of our chief residents, Christopher Young. And as you can see, it starts #MRPearls. So this is a collection of all the clinical pearls from every morning report we've done this year. You can go on the internet and search #MRPearls, and it's going to pull up everything that we've been learning in conference this year. I know this because I checked today, and it definitely works. And you're going to see all of the chief residents, but you're also actually going to see a lot of our APDs are using this when they're teaching, and even JAMA retweeted us, and that one came up really high, I think. So you can go and kind of see this. And each of these has these fun little snippets of learning that we got from our morning report. For example, this one says 20% of patients with HCV have arthropathies. Now, I am VCU trained, so instantly I thought to myself, I don't know if I believe that's true. And that's why Twitter is so wonderful, because you can look beneath it, and right there, Chris has included the link. And so I can click that and I can see who wrote this paper, where it came from, where they came up with this number, and then read anything else I feel is I need to actually believe it or disbelieve it. The next tweet that came up was in response to Dr. Mike Stevens. Now I'm paraphrasing here. I can't actually remember exactly what he said, but I think he was speaking to his expanded learning network, which is very vast, and was asking people to share some of their favorite subtle physical exam findings. And this is Gus Whalen, one of our primary care attendings here, who is sharing one of his favorites, which is using the clavicle to estimate JVP. And again, he's really using Twitter very appropriately by including a link to a video here. So the Stanford Medicine 25 has all these different physical exam videos. And I know this because I clicked on this link and I watched the video, and then I continued down this rabbit hole and watched a gait disturbances video, and there was one on nystagmus, and just continued to expand what I was learning. Next, I have one of our third-year residents, Barb Wash, who is sharing a resource that he used for Journal Club that was from the Clinical Problem Solvers, who are these wonderful podcasters who look at diagnostic reasoning, and they've made this blog that is filled with different examples of how a medical resident could use a likelihood ratio. And just by clicking this, it's going to take you to all this, and you can read this. And he was sharing it with his colleagues because he thought it was helpful. Next, we have Dr. Vinikova, or at Kidney Wars, one of our wonderful tweeters, sharing a tweetorial or a grouping of small teaching tweets, let's say, that is helping her fellows work on having difficult conversations. And so by clicking this, it's going to take you to this whole other list of somebody teaching about that. Then we have Michelle Brooks, one of our most prolific tweeters and associate program director, sharing medical education resource. Again, that'll take you to a tutorial. Then Nate Warner, which I think you remember from before, is just sharing an anecdote. And that's another great thing that Twitter can do, is you can just have somebody who's more experienced sharing with you an idea. And his is about a physical exam. By holding a piece of paper, you can make a tremor more obvious. And then this tweet I really like. So this is Dr. Kalahasti, and he's just sharing some successes of the electrophysiologist here at VCU. And what this does, to me at least as a learner here, it shows me that I'm getting education from people who are being asked to talk around the world about this. These are experts who are talking to me. At the same time, while sharing this picture, it just makes these people that are so intimidating to me because they're so intelligent seem like somebody I could go and ask a question to, and really decreasing some of those hierarchies that Twitter is known to do. And then this is something that I just love to be able to do with our Twitter account, and that's celebrate what our residents are doing. So this is one of our second-year residents, Ravi Choksi, and he was actually first author on this paper about IV cankerlor as an antiplatelet bridge therapy. And so Twitter allows us to share this with all the other residents so that all our other residents can see what people are doing and what they can be doing. But it's so much more than that. It also lets us share it and celebrate it with his medical school, with the VA where he did his research, with his advisor, who I'm sure has helped him through this as well. And then of course his mentors who helped him on this project and the journal that published it. And then we get to share the actual link. And that's where this really brings power, because every time you click on this link, it builds his paper higher and higher, and more people can see it. And this is how we can really help our early researchers, help get people's name out there. This tweet was looked at, I think it was something over like 3,000 times. So it's really wonderful to be able to get to share this with the world. So you might be thinking now, who is doing all this tweeting? I told you guys, I came into already a really rich Twitter environment. So all of these blue bars are how many people that I was aware of were tweeting at the beginning of this year. And then the yellow bars are our more up-to-date numbers of how many people have joined us since. I actually had to update this week, I think, because Dr. Kevin Singh in HEMONC and then Dr. Spencer Harris, one of our interns, joined, and I had to update it. As you can see, we have 48 total residents. And then our next biggest department is cardiology with 40, and that's at the VA and MCV. All of these are across VA and MCV. And altogether in the Department of Internal Medicine, my estimate is that I have 198 people I'm aware of. I'm sure there are more. So you might be thinking, how are we doing on these goals we set out on so many years ago? So first looking at, we were wondering this too, honestly. And so we asked our residents in the program survey, what are you using Twitter for? What do you like about it? How can it help you? One of our residents wrote, Twitter allows me to gain exposure to ideas outside of VCU and new ideas that differ from things that are cultural, which is almost the definition of expanding your network. So we were very excited about that. And then I use Twitter to learn about new emerging topics and great resources for reference. And I use Twitter to keep up with knowledge about the most up-to-date trends in cardiology. So I think we're on the right path. I think we're starting out on the right path in general, and it's really exciting. I do want to spend the last few minutes talking about some of the things that Twitter has done for us that we didn't really expect it to do, some of those unexpected successes that we found. So Twitter has allowed us to, or at least has allowed the chiefs to expand our med ed network. And so here's just an example of how it's done that. So in the ambulatory morning report this year, the chiefs have been putting on evidence-based debates with our residents. And we were trying to come up with a topic for our next one because Russia and Ted were going to debate. We wanted to have a really good topic. And we came up with a few, and as you can see, and then we just asked. And by the end of the day, we have all these answers from across the country of all these wonderful people who are great medical educators and all of their ideas. And it's just kind of unbelievable to believe that I would have access to these people's, information. For goodness sakes, we have Bob Centaur here weighing in on that day. And then I have a fellowship director in GI from somewhere. And then I also have chief residents in Ohio State University. Just if you're wondering, we did end up going up with Dr. Hertz from Emory's screening PSA. It was a lot of fun. The next thing that we're really excited about sharing is that we're really getting the VCU residency name out there. We didn't really mean for this to happen, but it's happening. In the last 28 days, according to our analytics, 1,500 people have looked at our profile. So they're seeing our mission statement and they're seeing all the cool things we're doing and posting and all the things we're sharing. And it's really exciting. We get to share that with the world. And our teaching resources are getting used worldwide. For example, this is a tutorial that Jared Dyer built on pleural effusions for our residents. And it's a string of tweets that include all these different learning resources. And it was so good and so magnificent. And everybody, I guess, agreed because it just kept being shared and being shared. And as you can see, people are reading it in Russia and India and Colombia. And it ended up being seen by, I think, 32,000 people. So we're really broadening our reach. But what I think I like most about Twitter, and the thing I'm most excited about that happened this year, is actually not how broad we've gone, but how close it brings us together at VCU. All these people that I felt like I knew, I just feel like I'm seeing a different side of them, and it's lowering those hierarchies. And I've really highlighted our department here, but it makes me feel closer to our surgeons and our emergency medicine department colleagues and people in pediatrics. And it just makes me feel like we're in a small, close environment. And I guess I'm not the only one, because one of our interns wrote, Twitter makes the program feel smaller and closer as I get to see the thoughts and responses of upper levels and attendings. And for people like me who are about to leave VCU, I get to take all you guys with me, which is wonderful. I get to take Jared, who's gonna tell me when I'm wrong, anywhere I go, which is wonderful. I get to have Mike Stevens, who's gonna, keep cheering us along, and see dogs on call, and still gonna have Michelle to help promote what I'm talking about. And that's just very special. I'm gonna take a moment to say thank you and show you all the people that are out there with us. I know I said there were 200 of us, but this is even more than 200 because I've included our alumni on here as well. And I'm really excited to show you guys that we already have 6 followers coming into our intern class. So we're ready to move on to the next group. And I'm really excited to see what the chiefs are going to do with it next year. It's a powerful tool. And thank you, of course, again to Michelle Brooks, who's taught me everything I know about Twitter. And then thank you to the rest of the residency leadership for really helping us with this project. And then thank you to all of you who are tweeting with us. You guys really made this happen. So thank you. I'm going to turn it back over to Chris.
It's hard to stand back up here and not get choked up thinking about all of that. I am going to rehash our learning objectives. Before I go ahead and do that though, I want to reiterate and emphasize that no cool project, no cool innovations happen in a vacuum. In fact, it's quite the opposite. They happen in the nurturing environment of a Department of Medicine that has an uncompromising dedication to innovation, pushing the envelope, and improvement from an education standpoint. So none of this happens without the support of our department. So we wanted to focus on just 4 of the cool innovations that we have been able to be a part of. And again, we talked to you about the MS4 near peer teaching. We talked to you about emergency response training at the learner manager phase over at the VA. We talked about our updates to our core conference structure. And we talked about medical Twitter and the expanded learning networks. We want to thank everyone for giving us the opportunity as chief residents this year to serve you. It truly is an honor, and I can speak on behalf of all 5 of us that it is an honor to serve in this role and be a part of this residency community and departmental community. So thank you so much for that. We would be remiss to not introduce the next generation of internal medicine chief residents. We could not be more excited to be passing the baton off to this group, and they're going to do a wonderful job guiding this program forward. So Kat Hess will be our resident chief, Lee Johnson, our ambulatory chief, Adnan Khan, our quality chief, Taylor Curtin Davis will be our intern chief, and Michael Sternberg will take over as our conference chief. We do want to take a moment at the end of this talk to thank everyone involved. And you saw us mention numerous mentors and people that have been influential in all of these projects and in all of our growth. It's impossible to enumerate everyone that has been involved in shepherding us through all these processes. We do want to particularly thank our associate program directors who have served as mentors through us the entire time, Dr. Syme and the leadership of the Department of Medicine that have cultured this environment in which we can do this kind of thing and be a part of these really cool innovations. We are going to embarrass her for a second and thank Dr. Stephanie Cole, especially as she transitions out of her role as the program director. And I think I can speak on behalf of a lot of people out there in the audience as well, do want to thank Stephanie Cole, and we're showing a photo of her in her favorite environment, and that is a teaching environment, for her mentorship, really at a personal level and at a program level. And I don't think any of us would have had the growth, and I think I can speak for most of us, none of us would have had the growth that we have had, both as educators, as doctors, as human beings without Dr. Cole. So thank you very much. I'm going to open the floor for questions. Feel free to question via the chat, and we will have that pulled up. Thank you, Laura. I think everyone can see it. So we'll give another moment for questions in case people are typing.
For those of you who can't read the chat, everybody's congratulating you on what was really a fabulous grand ride. We're very proud of everything that you do. Thank you for sharing.
Thank you all very much, and hope everyone has a wonderful day.